and on behalf of Boston, I would like to thank you for joining the session today. We very much want this to be a session where you learn as much as possible. So there is a question and answer box at the bottom of your screen. If you do have questions you wish to ask our faculty, please do feel free to write your questions in the Q&A box, and we will try to answer as many questions as we can during the session today. If everybody is okay, I would like to record the session. I will give you 1 minute or so in the chat box. If you have an objection to us recording, then please speak now, or I would ask you to hold your peace. So just for a moment now, if you would let me know if you are unhappy with us recording it, this is the opportunity to say so. Okay, thank you very much. So I am now beginning to record the session. So we are very fortunate today to have, as I said, a world-class faculty, which I would like to introduce to you. The subject of today's discussion will be a multifactorial overview about penile implant surgery in relation to all elements of penile implantation. And we will also include an overview related to the coronavirus situation that we are currently, sadly, finding ourselves in. So I will take a small introduction to each of our faculty members prior to a short review of the impact that COVID-19 has had on some of their clinical practice and how they perceive things have changed and how they may need to develop in the future as well. We will try to cover different elements of penile implant surgery today. So we will look at different types and different stages of surgery and when you might think about those, as well as the anatomy and physiology related to some of that. We will also look at some local, regional and cultural aspects that may be part of your decision-making process, no matter where you live, depending on the type of clientele and patients that may present to you. As I said, we do very much want to try and make this an interactive session. So if you do have questions that you wish to pose to our faculty, please do feel free to do so as we go through the session today. So first and foremost, let me introduce you to Enrique Lledo. I'm very fortunate to work with all 3 of these faculty on a number of occasions. Enrique is based in Madrid, where he is the head of the Andrology and Male Urethro-Genital Reconstructive Unit at the Hospital Gregorio Maranon in the centre of Madrid. He's part of our global faculty and indeed helps us both in terms of our education, but also our direction as a company when we look at which products we're going to develop and how we should try and support you and more importantly the patients when we're moving forward with any development that we have. He's also one of the key editors of a brand new textbook on sexual medicine and male sexual dysfunction that will be being available through the European Society of Sexual Medicine, probably in September or October. So we are very fortunate. And again, Enrique, thank you for giving us the time that you're giving us today. We really do appreciate it. Gabriella is based in Rome. Gabriella's practice takes...
Happy to meet you.
Thank you. Gabriella is based in Rome, predominantly, but he also works a little bit in the United States, as well as other countries around Europe and also in the Caribbean area as well. He predominantly works in the private sector, but he's also a lecturer in reconstructive andrology at the Sapienza University in Rome, where he's an associate professor. He has a huge practice and he's performed in excess of 5,000 uroandrological surgeries over the course of his career. And he was the first surgeon to perform the minimally invasive technique intrapubically for the implantation of the 3-piece penile implant. And certainly today he's going to be focusing on discussing that with you later on in the session. So again, Gabriella, thank you very much for joining us from your home in Rome. Really appreciate it.
Thank you very much for your kind invitation.
That's all right. Salah is also a professor based in Riyadh. And I was very fortunate to support him and his team in the first masterclass that we held in Riyadh, looking at penile implant surgery, both with didactic presentations, as well as a cadaveric experience and some semi-live and live surgery late last year. He is also the program director the andrology fellowship in the hospital they worked, which is the King Saud Hospital in Riyadh. He is also the current president of the Men's Health Association in Saudi Arabia, as I'm sure some of you who are on the call already know well. He has a large amount of peer-reviewed papers, both locally and internationally, and he's also been involved in several book publications as well, and he's an editor of multiple scientific journals. His primary focus of research, as it says here, is male infertility as well as erectile dysfunction, and also minimal access to urology. I've also been very fortunate to be involved with all three of our faculty today in teaching them about the resumed steam therapy for benign prostate disease, which for those of you who've not come across that yet, is a new or newer, minimally invasive therapy, day case surgery for the treatment of BPH in men. So again, Salah, thank you very, very much for joining us today for this session.
It's my pleasure. I'm looking forward for a very productive time to everybody.
Thank you. So before we go much further, I would just like to ask our audience a quick question, and that is whether you are currently performing penile implant surgery at the moment in your clinical practice. So we would ask you if you wouldn't mind answering this, that would be very, very helpful, and thank you for those of you who are already doing so at an early stage. So this is a very simple question of whether you are or whether you're not, or whether you're in a position where you are considering beginning penile implant surgery, maybe in the next few months or in the next year or two. So I will just give you another minute or so to answer that question. Whilst we are waiting, Salah, how long have you been performing andrology surgery or penile implant surgery in your clinical practice?
Basically, I finished my andrology fellowship training program at University of Toronto in 2006, and I'm back home in 2007. And since then, we established the andrology unit in the hospital, and we started thinking of doing the first penile implant in 2008. So since 2008, we have been working on this. I would say we started with the malleable prosthesis. Then after a few months, we started implanting the 2 pieces and 3 pieces penile prosthesis. And so far, most of our work is on 3 pieces penile prosthesis.
Okay, thank you. Okay, so I'm just going to share the results. So an interesting division of people, and thank you for those of you who agreed to vote. So most of you are performing some degree of penile implant surgery or penile prosthesis surgery at the moment. Some of you are not, and others of you are considering it for the future as well. So an interesting split of people. So we hope those of you who are already performing learn something additional for your practice or some considerations. And those of you who have not, maybe this would encourage you to consider it for your patients at a future date. So thank you very much for sharing your thoughts on that. We really appreciate it. So what we'd like to do first is we'd like to just take a short tour really through some of the impact that COVID-19 has had on all of our faculty. And first of all, I would like to introduce Enrique to present on this. Enrique, I'm going to try and give you control if I possibly can. Just bear with me a second. Enrique, I can only give you control to be able to...
If we see that we are not able...
I don't think it's going to be possible. I think it's only going to be possible for you to advance or I think it's only going to be possible for you to advance the slides.
No problem. No problem. No problem. Don't worry.
Okay. So...
Yes, sure. Don't worry. We can go ahead with this presentation. Okay. So you have to change the slide, I understand, because I am not able to change the slide. Okay. So I will try to. We can go ahead to the next slide. The situation here in Spain was really dramatic, as long as you know, probably more or less the same as in Italy. And the first phase of this dramatic period was around March, more or less. At that time, we only had the point of cancellation of all the activity in the hospital. all the urology department beds were reconverted to COVID patients, as you see, and all the consultation turned to telemedicine consultation, only oncologic or high priority oncological and also urgent surgeries were performed, and obviously the control of the PCR test before the surgery was done in all the cases. As long as you know, in the first period, in the first time of the disease, some patients were operated with an unknown situation of positive PCR test, and this situation increased the rate of deaths after the surgery. So it was critical to know about the PCR situation before the surgery. So we can go ahead with the next slide. Russell, after this situation, around April, more or less, the end of April, first 15 days of May, we started to change again to the progressively normal situation. In around 7 to 10 days, all the urology patients, but we didn't start with operations of all the patients. We started with uro-oncological patients. We kept on telemedicine consultation. Patients didn't come to meet us until more or less the first days of June. And after this, we can go ahead. All the situation around June, more or less the end of May or June, we went through the normal situation, more or less normal situation. I mean, we have maintained this situation nowadays. We only limit the number of visitors to the patients who are being operated, but we have restarted the program of penile prosthesis and sphincters since 1 month, 2 months ago, more or less. I started to perform again penile prosthesis surgery in June, and we have tried to recover all the numbers of patients that we were not able to do in that so dramatical phase. We can go ahead. So the most important now is not what happened, because what happened we know perfectly. The thing is why it happened, why we had in the past to stop these kind of surgeries. We know perfectly that erectile dysfunction or sexual dysfunction are non-life-threatening diseases, but they are really high prevalent in the general populations, and they have a lot of consequences in the quality of life and discomfort for all the patients. We are talking about erectile dysfunction, peyronie disease, also reconstructive surgeries, urinary incontinence patients. So what can we do? I mean, we can wait, and we must wait several months or maybe 1 year, for example, in these patients, because they are not urgent, they are not priority, but we cannot stop all this program of surgeries, and we have to look for solutions to treat these patients. We can go ahead, Russell. So with this scenario, we can say that also the decision-making process also depends on the local control of the infectious outbreak and the structure of each centers, which we can consider that we have some hospitals that are clean places, and also other hospitals, big hospitals, where all the patients are sent to remain when they get the infection. So it depends also, the management of the situation depends also on not only on each country and each city, but also in each hospital. What I want to tell you is that we have to look for solutions also in the current situation. Now in Spain, we are starting another sprout of the infection. We are facing another surge of the COVID numbers. We are increasing dramatically. Probably now in Spain, we are the country with the highest numbers now in the European Union. Probably this is summer, people has gone to holidays. I don't know for sure the reason, but here in Madrid and also in other cities, we are facing an important increase in the numbers. So the question is, do we have to stop again the penile prosthesis surgery program? I think not. I think we can go ahead, Russell. We have to look for solutions, and probably the solutions remain on these 3 points. First of all, to create reference centers for penile short stay surgeries. We have to be able to maintain these reference centers, at least places inside of the reference centers for these patients as clean places in order to create only places for them and not for only high-risk patients. This means to create clean areas and highly demanding and protocolized security check processes. Obviously, the surgery itself of in risk of COVID-19 infection, but it's important to maintain the safety of all the patients who come. We have to be able to perform the PCR test and the serology test and try to maintain these patients only at the hospital 1 day or as a maximum 2 days and not more time. We can go ahead, Russell.
Thank you.
Next slide, please. Next slide, please. Okay. And finally, obviously, this is my final slide. We have to think that in a country as Spain, where we have national security, national finance health system, this produces a very big problem because we have an ethical problem. We have to cure these patients. We have to give solutions to these patients. We cannot avoid the treatment of these patients. Also strategical and economical, because if these patients are not operated in the public hospitals, probably they are going to look for solutions in the private practice. This obviously is good for doctors in the sense that they can do a very nice surgery and get money. But this is not good for the patients because here, at least here in Spain, patients has the right to get this treatment financed by the public health system. So in the end, we have to be able to live with the virus, because the virus is still to be here for several months or years, but we cannot stop the activity. We have to also be able to create clean areas and clean places to maintain the activity also with these non-oncological patients, but patients who need this treatment to increase their quality of life. And this is my my suggestions to this situation, at least here in Spain. Thank you.
Thank you very much, Enrique. We really appreciate that viewpoint. A quick question to the audience now. We know certainly from my experience with our faculty and with multiple other physicians in Europe that the COVID-19 has had a dramatic impact on all surgical practice and all patient interactions. But what we would like to ask you is whether you have seen a dramatic change, and also how much of a change have you noticed in your clinical practice during the pandemic? So a poll is now on your screens, simply asking if you have seen a dramatic increase, and what sort of level has that increase, that big decrease been? Has it been that you're down more than 60%? Have you noticed no decrease at all in your surgical abilities around erectile dysfunction? Is it 20, 40, or 60%, or something of this nature? And again, we'll just give you a minute or so to answer that question. To those of you who joined the call more recently since I started, I would just like to point out that we are recording today's session, and I hope that's acceptable to each of you. So thank you for that. Whilst we're just giving people a little bit more time to answer, Gabriella, obviously your practice I know has been impacted. Roughly, how much time was it that you were almost unable to perform any penile implants in Rome?
But in Italy, the situation is very similar, like in Spain. We have a lot of hospital in Lombardia. You know very well, is the region in Italy region with the most important cases of COVID-19. Also in Rome, we have the problem, and the largest part of the hospital has only COVID recovery, only COVID hospital. We transform all the beds in COVID beds. And I very agree with Enrique because the needs of the penile implant is not very important. In my personal experience, I'm working in hospital and I saw the same situation, but I have a good practice in private, and we have a lot of insurances that cover the penile prosthesis implant, and a lot of people wanted the implant after the lockdown. During the lockdown, my activity is very poor. I had almost 3 or 4 implants. After the lockdown, since June, in 2 months, I had 28 implants in Italy. But all the implants was covered by the insurances.
Okay, thank you for that. Really appreciate it. Again, interesting set of results that we've got from this poll. And again, thank you to those of you who participated, and a large number of you participated. So we really do appreciate that. I think what we're seeing, gentlemen, I value your input here. What we're seeing is obviously that most people have seen some reduction in their surgery, and most have seen a significant reduction. If we look at 57% of people, it's down at least 60%. So would that reflect, Salah, would that reflect roughly what you're seeing in Saudi as well?
I would say even more than 60% because most of those implants are done non-insured, so people have to pay out of their pockets. Governmental hospitals who used to do them for free are shut down because of the COVID, so that's marked reduction in the number of prostheses being performed. And the people who can pay out of their pockets for the prosthesis, they prefer to delay the procedure till they have a clear situation regarding COVID. So I would say more than 80% have been affected.
Thank you for that. I really appreciate it. And again, thank you to our panelists and also to our audience for taking part in that poll. Salah, would you like to give us your viewpoint from the Saudi Arabian perspective, please?
Okay, so next slide, please. So the situation is similar to the situation encountered in most of the world. At the beginning of the pandemic, the urology beds have been shut down and converted into a common pool beds for COVID-19 patients. Based on this, our elective surgeries and capacity for operation have been markedly reduced and restricted only for priority cases, including oncological, urological procedures or trauma cases, or life or limb-threatening situations. Other than this, all cases have been postponed until further notice. A similar impact on the outpatient clinic. Usually there is no in-office or in-clinic consultations. It's been done by a phone consultation, contact with the patients, and in very rare situations where we have to ask the patient to come physically to the hospital under very restricted situation, including the screening at the entry of the hospital. A patient have to wear a face mask. We have to maintain the number of people inside the clinic to only 2, including the nurse and the physician. Maintain social distancing, and we will not allow any companion with the patient to attend the consultations. For the life-threatening or critical conditions, usually it's the hospital policy to screen before the surgery by 24 hours with PCR test, and if the test is negative, then the case will be proceeded, and if it's positive, then usually it goes cancelled if possible, if this will not affect severely the patient outcome. Next slide, please. As Enrique have said, the andrological procedures is a low priority surgery, so they have been cancelled and postponed until further notice. And I have to say, since March, we have not done any penile prosthesis. We start opening up from June, beginning of July. We start going back to operate again on penile surgeries and other andrological procedures for infertility. We started first in the private sector because the policies and the ease of restriction is much more compared to the governmental hospital. As you know, the governmental hospital is the main location for COVID-19 admissions. So most of the COVID-19 patients go for governmental hospital, and that's why the hospital beds have been utilized by them. And as last week, we start operating in the governmental hospital, but again under very strict condition. Next slide, please. So 50% have been resumed for the operating capacity, but again, we have to prioritize our patients because we have a backlog, a lot of patients now accumulated. So priority is for patients who have waited for longer or patients with, again, ecological or life or limb-threatening conditions. Clinic visits have been allowed at a 50% reduction, and we're expecting, starting from September, to increase the capacity to 75%. Hopefully by October, we'll go back to 100% if the numbers are not increasing. Most of our cases now, if we have to do it, ideally it should be done on the same day, on the same discharge. And patient usually been admitted on the same day to a very special admitting ward where all the tests have been or should be reviewed, and the PCR test that should be also done 24 hours should be confirmed negative before we proceed with the surgery. Next slide, please. Based on this, how we go forward, starting from this point, we have to be very clear with our patients when it comes to legal considerations. I agree with Enrique. Those patients must be extensively informed that there is a possible transmission for COVID-19 beyond our control, because really we don't have any tests to confirm asymptomatic carriers or asymptomatic patients who have been infected. 24 hours PCR testing is good in most of the situation, but will not guarantee absence of infection. So patients have to be really informed about this, and we are considering putting this in written when it comes to consent. Also, we have to look forward for the coming 3 months, how to prioritize our patients when it comes to scheduling their surgeries. As a urologist before being an andrologist, we have also cases related to prostate, kidney cancers, and bladder cancers, as well as stones. And those are competing with the time allowed for andrological procedures to happen. So this is my last slide for the COVID-19 situation as we speak.
Thank you very much again for that overview. And to the audience, we just wanted to give you a short, brief, real overview from 3 different perspectives. And again, if you've got something that you want to add to that discussion, please do feel free to either put it into the Q&A box or to the chat box, and we can share that with the rest of the audience as well. For now, I would just like to ask you another quick question. So what we would like to know is, obviously we're now looking hopefully towards, in many countries, a new era in a post-COVID-19 pandemic phase, or certainly a reduction in the amount of cases that we're seeing, and an increasing opportunity for your situation, that surgery will start to return to near normal pre-COVID-19 levels again. Will that be in 2020 or 2021? Or do you feel that really, because things are so fluctuable at the moment and we're still seeing spikes and peaks in some countries, if it's really too soon to decide this at this stage. But Salah, from your point of view, when do you think that you'll be back to a level that you were at before the COVID-19 pandemic broke out? Roughly?
Well, as I said in my previous introduction, we are forecasting by October we should go back to 100% operation capacity, pending the numbers that might show up during the summertime, starting from September. Okay, thank you. And what about you, Enrique? Obviously, I appreciate that Spain is seeing a significant rise at the moment.
Yes, we have now, as I told you before, a significant rise. Our hope is this rise is only depending on the vacation, on the holidays, and early is going back again to the previous values of infected patients, but it's difficult to answer this question. I mean, the question is, again, to be able to create clean places and clean protocols to treat the patients. Just one day, I have just started, and I am doing now, in this last month, I have done some both penoscrotal and infrapubic approaches with just 1 day patient, with just 1 day at the hospital for the patients with no complications and no problems. The patient comes in the morning and goes home in the afternoon. And I think this is okay. No problems. And I think reduce the rate of infections in these patients. Regarding the possibility of going back to the lockdown, we will see in the fall what happens. It's very difficult to answer these questions that you have done, Russell. It does not depend on our acts in the end. It depends on the presence or not of the vaccine, or in the common sense of the population, and also of our politics. So this is a non-answered question and very difficult question to answer, really.
I agree, and I certainly think our politicians, certainly, I can only speak from the UK's perspective, but some of the decisions that politicians make sometimes make no clinical sense to those of us with any form of medical background. So I would completely appreciate and agree with you there. Thank you for all of you who have answered to our poll again. And again, we've got some interesting results. You know, a lot of you, I think, are under the expectation that certainly 2020 is not the period of time that you will see a return to pre-COVID-19s. And I think our faculty in broad terms would agree with you on that, definitely. It is very difficult to predict at the moment, and we will have to wait and see. But again, thank you very much for that. That's really appreciated for you to share your thoughts and feelings on that. So what we would like to do now is we'd like to move into the main part of our presentation today, which is to look at some of those local, regional and cultural aspects, as well as the different techniques and tips and tricks around various elements of penile implant surgery at all levels. And what I've tried to do here is I've tried to make it a nice progressive approach so that it makes sense to, it certainly makes sense to me. I hope it makes sense to you as well. What we're going to ask first is I'm going to ask Salah to discuss both malleable and two-piece penile implants and give us some perspectives around the Saudi Arabian and around the Islamic world's perspective on this. So Salah, again, thank you for your support in doing so. And if you're happy, we'll move forward to the next slide.
Great. Now, this is really reflecting the culture in the Middle East, mainly in the Arab countries, which is a journey when you start thinking about implanting a penile prosthesis for a gentleman. It starts from preoperative counseling to postoperative care. And this is my take when it comes to preoperative consideration. I would say, generally speaking, but more precise on the Middle Eastern population, men. So for this, as with any patients undergoing penile prosthesis counseling, please do not offer prosthesis insertion except after exhausting all other treatment modalities. Sometimes you might be challenged by a patient who are skipping the cascade for medical treatment for erectile dysfunction, and you would like to just go forward right away to the penile or surgical interventions. I would caution and I would think many times before accepting this patient in doing so with very extensive counseling and written documentations. I have to say also from the prospective Saudi patients, vacuum constriction devices as an element for treating erectile dysfunction is poorly accepted by patients, and the compliance rate with them is very poor and very less likely to be tolerated. So it can be very easily omitted from your counseling when you counsel patients for possible options for treatment of erectile dysfunction. You have to consider present and future sexual activity of the patient and his partner. Some people, and this is the underlying belief of some people when they have erectile dysfunction, to get married to a very young female partner, wife, and that might improve his sexual activity. And in actual fact, that might discover his underlying problem and put him in a very severe trouble. And he comes to you shopping for options in a desperate way. So this have to be calculated very well when it comes to patient counseling. And I have to emphasize also with any patients anywhere in the region or outside the region, you have to lower patient expectation. You have to undersell your items. This is against the marketing strategy or outside the business of andrology. If you lower the patient expectations, the post-operative satisfaction rate will go higher. Next slide, please.
Salah, just very briefly, we've got one of our delegates has actually raised their hand to ask a question. So I'm just going to allow them to do that. So Yazko, I'm sorry if I say your name wrong. I've just opened your microphone. So did you have if you unmute yourself, do you have a question you wish to ask? If not, and it can wait a little moment, then we can try and make it in a moment or two. Let's carry on, and we'll come back to your question in a little moment or
so. The slide before that, please. So it's our policy not to operate on a patient with a hemoglobin A1C above 8. This is for multiple reasons, and we have published already a paper on this as a cutoff point for hemoglobin A1C. So we do our best to control the patient's glycemia within that range or lower if possible before the surgery. The patient have to have a negative urine culture and no open skin wound lesion before the surgery. This is all have to be checked out in the preoperative evaluation of the patient. I would have to say also there is no age limit for our patients when it goes to penile surgery. The patient can walk, and in a good physical fitness, he is a good candidate for penile surgery. Nowadays, we can do a penile surgery in terms of malleable penile prosthesis and a good local anesthesia within a very short period of time. We have to assess the patient manual dexterity when it comes to the options of penile prosthesis. Patients who have compromised the manual dexterity should be counseled against using inflatable prosthesis, unless if the patient is having a very willing and adherent partner who can help him in the pump activation and deactivation. Otherwise, this patient might be suited and served very well with a malleable penile prosthesis. Next slide, please. I have to say also, most of the Saudi patients from our experience above the age of 70, in that range, they have a problem with the activation of penile pump. So most of them, they deviate away from inflatable penile prosthesis, and they choose with extensive counseling to go for malleable penile prosthesis for the ease of use and their understanding that this might be also stays with them longer when it comes to mechanical failure, although the mechanical failure is not a much concern, and I will talk to about this in the next slide. Concealment of semi-rigid penile prosthesis is not a problem with in a Saudi patients, in Arab patients who wear the thawb, which is the national male dress. And I can show you the next slide, the usual dress, the usual national dress for Saudi men. Next slide, please. Which is very redundant and can hide any details. So privacy and confidence is not an issue with semi-rigid penile prosthesis for people who are using this type of dress. Next slide, please. Next slide, please. You have also to consider and discuss with the patient the reoperation rates, the prosthesis survival time, and the costs before selecting the prosthesis. Also, in my practice, I always warn the patient that the penis might be a little bit shorter and the girth might be a little bit smaller than before. Again, this is the strategy of lowering the patient's expectation to avoid any troubles later on postoperatively. The glans might be soft, might not be supported very well, and might be cold, which is correct with any type of penile prosthesis. And I have also to inform my patient that the penile prosthesis provide only rigidity. If your libido is good before the surgery, it will maintain normal libido after the surgery. It will not affect your urination, and most of the time it will not affect the ejaculation or orgasm. And once the device is removed in case of infection and you cannot do anything about it, you will have no more erection. And this has to be clearly written in our consent to our patients. It is our practice that for the tradition of people in the Arab world not to ask him to bring his spouse for the consultation. Next slide, please. Now, when it comes to the types of penile prosthesis, as most of you know, there are two main broad categories. We have the malleable implants and we have the inflatable implants. Each one of those have its own advantage and drawbacks. When it comes to simplicity, low cost, and very easy and straightforward surgery, we're talking about malleable implants. But if the patient is requiring more physiological erections, more control, and more erection and flaccidity, we are talking about inflatable penile implants. Next slide, please. In the market, in our region, those are the main available types of prosthesis. When it comes to the malleable, we have the Tactile nowadays from Boston Scientific, and we have the Genesis from Coloplast. Two pieces inflatable penile prosthesis, the only available brand is Embicor from Boston Scientific. And for the three pieces, we have the three models from Boston Scientific's 700 series, and we have the Titan from Coloplast. Next slide, please. Also, I have to mention the three pieces penile prosthesis from Boston Scientific come with two types of reservoir. We have the spherical reservoir and we have the flat reservoir, which is a good one to implant if you are considering ectopic reservoir placement. Next slide, please.
So thank you for that, Stella. And we do have a question from the audience, gentlemen, which I'd like to take this opportunity to ask you. And that is, what about the transmission of COVID-19 during sexual intercourse? Is there any evidence that that occurs? And if so, what are the preventions, obviously, that can be taken to prevent that? Is there any evidence at all during sexual activity?
Personally, I haven't any experience, but I think with the condom is possible to prevent an infection, I think.
Okay.
But
I agree completely with Gabriele, because in the first part of the pandemic, some studies were published saying that the virus was not present at the semen, but in the last month, I have read at least one article saying that the virus is in the semen. So probably the best way of avoiding any risk of infection is using the condom. Completely agree with Gabriele.
Thank you very much.
I have to agree with that. The virus is shitting in the semen, but also sexual intercourse is not only intromission. It's also the virus can be transmitted by the droplets in terms of kissing and things like that.
That's right. That's right.
Super. Thank you very much, gentlemen, for answering, and I hope that answered the question for our participant. To the audience now, we would like to ask you a question around device selection. So, what are some of the considerations as our delegates? What are some of the considerations that you would consider when thinking about the device that you would choose for your or support your patient in making the choice for? And again, you can answer multiple choices on this one. The poll is open, so if you'd like to give us an indication of some of the things you think about when you are making those decisions with your patients and possibly with their partners as well. Obviously, I accept that in certain parts of the world, to ask the partner is less common, but in other parts, it's almost mandatory that you do. So, going to Salah's point about it's not common practice due to local considerations in Saudi Arabia. Gabriella, do you normally talk to your patients' partners as well, or is it predominantly the patients that are involved in the decision-making process?
In my experience in Italy, the patient asked me for the penile, 3 pieces penile implants, and the most largest part of my patient has a private insurance, and the cost is not very important for this.
But do they ask their partners? Do you tend to have the partner present when you're having the consultation, or no?
Yes, for sure. Yes,
Okay.
every time I show the prosthesis, I show all the types of the prosthesis. I have the malleable, I have the 3 pieces, the 2 pieces,
Okay.
but the largest part comes to me, ask me the 3 pieces, and then I show the device.
And Enrique, in your practice, does the partner normally attend with the patient, or is it a sort of a mix?
This is a very interesting question, and it's interesting to see the difference. For example, in Saudi Arabia and here in the rest of here in Spain, for example, here usually the partner comes with the patient, and I have to confess you that I like it. I prefer it, and sometimes the partner helps me to assist the patient to make the decision, because sometimes the patient is not has fear, is afraid about the surgery, but when you explain to him and to the partner some details, especially that he is going to be able to maintain the erection as long as they want, usually if the couple maintains a sexual activity, a really high sexual activity, the partner is going to push the patient to accept the implant. So sometimes I have to tell you that the partner helps me to assist the patient to make to go ahead with the decision. So I like to have the partner in my practice. Yes, I do.
Thank you for that. Let's see what the audience consider important. So an interesting array of answers, as I think we can agree and see here. So certainly age and weight are considerations. Very importantly, and I think it applies to everything that all three of you have just been talking about around manual dexterity, and of course cost, as Gabriella was mentioning, around insurance. What I do find interesting, and I'd value your input, is that the partner's wishes, nobody was taking those into account particularly during this process. So do you find that interesting, unusual, or what are your comments on that, gentlemen? Salah, obviously, and this is why it's very interesting to have your perspective from a Middle Eastern perspective. Is it something that is never considered in Saudi?
Well, I have to say, when during my training in Canada for andrology fellowship, the partner was always part of the consultation and discussion. But I have to say, since I came back, it is not the routine for the patient to bring his partner. I was trying at the beginning of my practice to convince the patient to bring his partner to come for discussion, to have a consensus agreement on what do you want and how do you go out of this. But I have to tell the tradition in this part of the world is much more different than the Western world. People tend to keep their things, especially when it comes to erectile function, at a very private discussion, and they don't like to involve anybody else in their selection.
Okay, thank you very much for that. And again, thank you to our delegates for giving us your insight and your inputs. Salah, back to you.
So now how to go from here when it comes to device selection, and this is my statistics that I got from my review. I understand the three pieces penile prosthesis is the gold standard among 70% of the people who go for implantation in the USA, 20% for the two pieces, and only 10% for the semi-rigid rods. So it's not very popular in North America. When it comes to Europe, it's 50% between the inflatable and the malleable. As I said before, when it comes to the Middle East, most of the implants goes to the malleable prosthesis, and 30% goes to the inflatable prosthesis. And this have many reasons to explain. As I said before, the ease of use, especially for people above the age of 70, they don't like to get involved with the pump activation and deactivation. I have to say also, most of the implants are not covered by, or I have to say all the implants are not covered by the insurance company. So the patients have only two options: either to do it at the governmental hospitals free of charge, and this is not available in all governmental hospitals, or patient have to pay out of pocket cash to get this done. So also financial perspective plays a major role in device selection when it comes to the patient choices. Next slide, please. From our side, as a professionals, we have also to consider multiple things when we counsel our patients. Of course, we have to bring all the possible options and the possible solutions and the devices on the table for the patients, but also we have to prioritize our options. It is very clear when you are dealing with a very athlete person, swimmer, teachers, inflatable prosthesis might be the best options for them, especially for people who are wearing very tight underwear. So malleable prosthesis might not be the best option. Patient with a history of urethral stricture or PPH, inflatable prosthesis also might be the best options for them. Patient with Peyronie disease, all options are available, but avoid the LGX from Boston Scientific because length expansion might exacerbate the curvature. So this is not a good option for patients with Peyronie disease. Therefore, if you just go for the models with restricted girth expansion, such as the CX model or the CXR, this is more appropriate for patients with Peyronie disease. Malleable prosthesis is another good option also for patients with Peyronie disease, especially if we're expecting to have a very difficult corporal dilatation, like in patients with small or fibrotic veins. Patients with manual dexterity, of course, mechanical is the best option for them, and try to avoid inflatable penile prosthesis. Patients with a high risk situation, you would like to implant the prosthesis in a very short period of time, the shortest possible. So semi-rigid prosthesis might be a best option, although inflatable prosthesis in a good hand, like Gabriel, where he inflate his he implant his infrapubic prosthesis within 15 minutes, that might be another option. Next slide, please. This slide basically talks about the same thing that I have mentioned before. So next slide. Now, when it comes to malleable penile prosthesis, as I said before, we have the old Spectra from Boston Scientific. This is a 2 cylinders with articulating segments. It's not available anymore in the market, and this have been largely replaced by the Tactra. Next slide, please. Next slide, please. So this is the new malleable prosthesis from Boston Scientific, introduced to the market last year. It is a malleable prosthesis with a double coverage of silicone and internal nitinol core. It can give you a 90-degree memory with a very strong axial rigidity. Next slide, please. So basically, this is the first Tactra that we have implanted in Saudi Arabia and in the MENA region. That was back in November 2019. I was just demonstrating the device itself, and we'll talk about it in the next slides.
I have to say I was there for that first implantation. It was a very exciting day, so thank you for that one.
We can go for next slide. So this Tactra is, as I said, it is covered by a dual layers of silicone. It has a nitinol core for extra rigidity. It can withstand up to 4.4 pounds of pressure. And for those people who might not know, for vaginal intermission, we need only 1.1 pounds of pressure. So this is stronger, 4 times the pressure that needed for vaginal penetration. Also, it has a 90-degree memory, so that also can be very comfortable for the patient when it comes to concealability and confidence and privacy. Usually, the malleable zone is at the distal part, and I will show in the next slide also the 3 different options for malleable prosthesis. It is durable, and this prosthesis has been cycled from 0 to 90-degree bending maneuvers 100,000 cycles without mechanical failure. And this is equivalent to twice of the expected device life of almost 10 years. Next slide, please. So these are the available 3 sizes, 9.5 and 11 and 13 millimeter. And you have to keep in mind when you choose the appropriate diameter and length for your patients, the smallest intracorporeal length that you can implant this is 14 centimeter. You cannot cut beyond this if you choose to go for the 9.5 diameter. And of course, if you choose higher diameter, the patient have to have a longer length of penis. Next slide, please. So this is the first Tactra that I have said before. It was implanted through the penis-scrotal approach back in 2019. Next slide, please. And this is his 3 months post-operative results. Very straight and very straight penis. Next slide, please. Next slide, please. And this is the lateral view. You can see it's very easily to bend and very easily to keep straight for vaginal intermission. Next slide, please.
So thank you for that. Just before we move on to another poll, another question from one of our audience. I'm assuming, again, there are regional variations on this, but have any of you implanted penile prostheses into homosexual males? And what are your thoughts on doing so? Do you take any additional precautions, or do you change the way that you may counsel your patients at all? Enrique, what about you? I'm assuming you've implanted in homosexual males. Does it make any difference in the way that you discuss them with your patients?
Not really. I mean, the homosexual patients, I think that they are very interested in covering all their expectations. They want to go to the operating room knowing everything about the surgery, all the risks, and they have to feel completely safe at the time they make the decision. Regarding the partner, they usually take the partner to meet us. The decision is made by all three: the doctor and the patient and the partner. And I like to talk about the rigidity. I mean, usually the homosexual intercourse, anal penetration, usually needs a higher rigidity in comparison to the vaginal penetration. So they have to be aware, and probably you have to show more sometimes than to the heterosexual patient the model. They have to touch it, they have to feel it completely full, and they have to feel very sure at the time they make the decision. They have to be completely informed, more than the usual patient, I think. And this, I think, it's the main difference. I mean, the characteristics of their sexual intercourse, the role they have, it's not the same according to the role they have in the sexual intercourse, but the rigidity in the setting of the homosexual intercourse is very, very important in my opinion. So you have to inform about it, and they have to be completely sure.
Okay, thank you for that.
Of all the information at the time they make the decision.
Thank you. Gabriella, what about you?
Yes, I had 5 or 6 homosexual men that implanted the prosthesis. I am agree with Enrique. You have to explain very well about the rigidity, because the penetration is different, and the expectation of the patient is a difference between the expectation of the heterosexual man. But all my patients are very satisfied, because they had erectile dysfunction before the implants, and now they can penetrate without any problem with just a little jelly. they can penetrate without any problem. But explain very well about the rigidity.
Thank you very much for that.
Russell, if you give me just 30 seconds, I
Please.
would add to the explanation of Gabriele that probably in the setting of the homosexual patient, in my opinion, infrapubic approach is better than the penoscrotal approach, because probably the morphological aspect of the penis, when you activate the prosthesis in the infrapubic approach, in my opinion, and my practice now is 50-50. I started to do it with Gabriele, and I enjoy a lot the infrapubic technique. And probably the morphological aspect of the penis, when you activate it, it's better with an infrapubic approach in comparison to the penoscrotal approach. And also, homosexual patients are really pending, they are more sexual active in comparison probably to the heterosexual patients who deserve a penile prosthesis, and also they are very pending also about the morphological aspect, the aesthetical aspect of their penis. So I would advise also, if the patient is not very old and they come with the partner and all this stuff, I would suggest the patient to go ahead with the infrapubic approach.
Thank you for that. Thank you very much, both of you, for your input there. To our audience now, it's time for you to answer another question. So what we would like to know is, if you are currently performing penile implant surgery, are you providing malleable two-piece, both malleable and two-piece, or are you providing every option to your patients all the time? So again, we'll just give you a minute or so to answer that question. I know we've heard from all of our faculty on this already, and I know, Salah, you provide all of them, and indeed your market is very dominant with malleable implants. Enrique, have you got much experience with two-piece implants at all?
I have implanted and I like it, but I mean, you have to select very carefully the patient. I have used it in patients with very catastrophic pelvic anatomy, patients with kidney transplants, patients with vascular surgeries, and patients who you think as a surgeon that the ectopic placement of the reservoir is not indicated or is not going to be feasible. So I think I'm really a strong supporter of the Ambicor device. I think it's a good device. I mean, you obviously need higher corporotomies, and probably it's not so, it's not so comfortable as device as the 3-piece, but I think it's a very good device in my opinion. I have used it definitively, and I keep on doing when I have opportunity.
Thank you. Well, we're gonna dive into the Ambicor in a minute, but before we do, it's interesting that most of you are indeed providing all the different options to your patients. About 50% of you are providing malleable 2-piece and 3-piece, with some of you providing purely malleable as well as the 2-piece possibly as well. So again, thank you for your insights on that, and it's interesting to see. Let's move forwards and just continue a little bit more about the malleable implant. Sela.
So this is just only continuation for the patient preparation before surgery, and I guess this is same for the malleable prosthesis in a similar way to the inflatable prosthesis. As I said before, it's our policy not to implant a patient with hemoglobin A1C above 8. We usually ask the patient to stop aspirin 1 week before the surgery, especially for 3-piece penile prosthesis. We are less strict when it comes to semi-rigid prosthesis. We have implanted, we used, and we continue doing implantation of malleable prosthesis on a patient on aspirin without asking them to stop it. But when it comes to Blavix, for instance, which is the chances for hemorrhage is much more, usually if it is malleable, we ask the patient to stop it 1 week before the surgery. We ask the patient to avoid any shaving before the surgery, washing before the night of the surgery. And for those old patients with some lower urinary tract symptoms, especially when there is something suggestive of a large prostate, we start them with alpha blockers before 1 week from the time of the surgery, especially when we are considering malleable penile prosthesis. The preoperative antibiotic is usually given 1 hour before the surgery, and we maintain an intraoperative antibiotic irrigation throughout the procedure. Next slide, please. This is the usual operative restrictions to avoid risk for infections. I will not spend much time about this, but I have to say it's not our routine also to insert a Foley catheter before the surgery when it comes to malleable prosthesis. And anything, we just insert in and out catheter, and we proceed with the surgery without catheter. Next slide, please. Now, this is the usual scrub for 5 to 10 minutes in the surgical patient area. Next slide, please. And this is the standard incision types. This all applies to malleable prosthesis. You can implant it in a subcoronal way. You can do it in a penoscrotal transverse or penoscrotal vertical, and you can also do it in the infrapubic way. I will have to say most of our implantations are either subcoronal or longitudinal vertical penoscrotal. Sometimes we have to do combination of the incisions, especially for those cases with a complex corbra or very fibrotic corbra where you need really to excise part of the corbra. Next slide, please. So subcoronal incision, I would advise to avoid it in a patient who have a vasculopathic morbidity, especially those patients with diabetes, because the risk of glands ischemia is something to consider, especially for diabetic patients. Next slide, please. I have to show you one of our patients who have underwent malleable penile prosthesis 2 years ago with a subcoronal incision. This is his glans picture after 1 day from the surgery. We thought this is only because some hematoma or ecchymosis from pulling over the glands during insertion of the rods. But and unfortunately, the patient lost follow-up. He was instructed to see us back after 48 hours, but he came back after 14 days. Next slide, please. And that was his picture after 14 days. You can see a very clear area of demarcation for glands ischemia. Fortunately, we could rescue the remaining part of the glands. The rod had been explanted right away, and he lost something like 10% of his glands volume. I have to say this patient is diabetic, on insulin, without any other risk factor. Next slide, please. This is other patients we have inherited from other centers who have been implanted outside actually the country. This is different pictures for glands necrosis, and all of those patients have been implanted with malleable penile prosthesis. Ended up by substantial tissue loss after debridement and removal of the prosthesis. Next slide, please. So keep in mind, glass necrosis post-operatively, it can happen by any approach, but it's more worse with subcoronal approach, especially in vasculopathic and diabetic patients. It can present as a dry gangrene or as a wet gangrene, and you have to recognize it very early, and you have to remove the prosthesis very early. And I have to say also, this is very underreported complications. In the literature, there was only 21 patients, and the last case series have been published by Wilson in 2017 for patients with glands necrosis, and that paper, for those people who are interested, can give you a very good outlook and how to deal with suspected cases of glands necrosis. Next slide, please. I have to remind you also with the anatomy of the penis, and that's why we have to be very careful when we choose subcoronal approach. As you know, the blood supply to the glans penis consists mainly of the dorsal penile artery, but also there are numerous supplies coming from the bulbourethral artery and the corpus spongiosum artery. So really, to have a glands necrosis, those blood supply branches have to be severely compromised. So patients who have previous urethral surgery, either hypospadias repair or urethroplasty, avoid at any cost implanting him through the subcoronal approach. Patients with vasculopath who have lower limb ischemia before, avoid this approach. Patients with poorly controlled diabetes also avoid this approach. And I have to say, all the case series that have been published by Wilson in 2007, those people, they were not diabetic. They were only implanted through the subcoronal approach. Next slide, please. So this is the risk factor for glands necrosis. I have already talked about them. And one of the risk factors also, if you apply a very strong pressure dressing to the penis and the glands after the surgery, that can impede already compromised blood supply to the glands. So the glands have to be exposed all the time of the surgery. You have to inspect the glands right away after the surgery and 6 hours and next day, and try to avoid any compressive dressing over that area. Next slide. Next slide, please. So the penoscrotal approach, I'm not going to talk about it. I will leave it for Enrique. But this is another possible option to go and implant your malleable prosthesis. The only thing I have to mention here, if you choose to go through penoscrotal approach for malleable rods, you have to have a generous corporotomy. As you know, if you bend the malleable rods, you have to have at least 3 centimeters. That's in my practice, 3 centimeter corporotomy to be able to insert the prosthesis without much difficulty. Next slide, please. Infrapubic, I will leave it for Gabriel. This is another option for implanting your malleable prosthesis. Next slide, please. We have recently adopted this new approach, popular by Dr. Habous and colleagues, which is the vertical proximal midline approach, where we do a 5 centimeter incisional length. It's much more cosmetic, and it can be extended in case if you would like to go for more reconstructive procedure in case of Peyronie disease. Next slide, please. So this is just illustration for the vertical extended approach. This is after you open the skin. This is how to open the buccal fascia and the dartos muscle in a transverse way. Next slide, please. Then after putting the stay stitches in both sides, you just open the corporal cavernosum and the dilatation in a usual fashion as any other approach. Next slide, please. The usual introduction for roads when you go through the penoscrotal or the vertical midline incision is to introduce the proximal part of the road first before the distal part. This is just to make your insertion easier. And as I said before, you have to have a very generous cavernotomy length for at least, in my practice, for 3 centimeters. Next slide, please. And this is how it looks after you insert the rods. Next slide. This is some surgical tips when it comes to inserting mandible prosthesis. As I said, adequate corporotomy incision to avoid struggle inserting the rods. If it's possible to dilate to the maximum number, which is number 14, this is the best for the patient acceptance, but try not to enforce it too much. Select the largest possible rod, and it is my practice not to oversize the rod. Usually I put 1 centimeter less than the intercorporeal length. As I said before, we insert proximal before the distal. And if you have any question about distal perforation, you have the liberty in suturing the rigid prosthesis to the corporotomy side. Also, it's very important when you consider inserting a malleable rods for an elderly patients with an element of penile prosthesis hyperplasia is to consider doing this 3 thumbs technique, where you put your 2 thumbs on the dorsal aspect of the shaft and 1 thumb at the proximal aspect. If it's too tight to feel in between, then the rods is too wide, and that might end up by irritation for your patients. You must have a little bit laxity and space between the 2 rods when you do this 3 thumbs technique. Next slide, please. This is another illustration for insertion of the malleable rods, proximal then distal. And next slide, and this is the next slide, please. And this is how it looks for the mammy wrap that we usually do after the surgery. You have to expose the glands, and you have to make sure there is no much pressure on the glands. We usually put an ice pack, and if the Foley catheter, we keep the Foley catheter after the surgery. We insert a Foley catheter, we keep it for 24 hours, then we can remove it. And we give the patient painkillers, and we encourage him for early ambulation. Next slide. There is not much specific about postoperative care for these patients. It's same as any approach. We maintain the penis in lifting position. Patient is encouraged to avoid any heavy weight lifting, and we cover the patient with antibiotic. We usually use Bactrim to avoid any MRSA resistant bugs. We maintain that usually between 1 week and 2 weeks. Patient can resume sexual activity usually after 3 weeks from a malleable prosthesis. And that will be my last slide for this part.
Thank you very much. A little question to the audience again now. We'll give Salah a little break for a second here. We've heard from our faculty regarding their use of Ambicore and how they feel that it fits into their practice. But what we would like to ask you is where you might consider it to be used. So I will just ask you a very simple question. Which patients would you specifically consider for a 2-piece implant? Would it be those that would wish for an inflatable device but have limited funding? Would it be those patients that have had specifically extensive abdominal surgery in their past? Or is it because you don't feel quite so comfortable in your current practice to implant a 3-piece, but you wish to give the patients a dynamic erection? Or are you unsure? So again, we'll just give you a minute or so to consider that. Gabriella, we're going to hear from Salah shortly about the use of Ambicor in his practice. Do you have much experience, and we've heard from Enrique as well, do you have much experience using the Ambicor, or are there patients that you consider for using a two-piece for?
I have not great experience for two reasons. The first one is the price in Italy is the same of the three pieces. And if the patient has the possibility to choose the three pieces prosthesis. I implanted the Ambicor in two cases with a previous extensive abdominal surgery. The patient had previous cystectomy and plasty, and if you have this kind of anatomy, I think it's better to implant the Ambicor. But in terms of money, sorry if I speak about money, but it's a real consideration to do. In Italy, the price is the same, and if the patient hasn't a lot of money, can choose between malleable or three pieces implant.
Thank you for that. Appreciate it. Again, what we're seeing is really to what all of our faculty have alluded to, is those patients that have had extensive abdominal surgery where you wish to avoid placing a reservoir in their abdomen might be the primary consideration for the use of an Ambicor. In certain markets, it may be a cost element to it, definitely. And again, thank you for the honesty of those people that have voted with the third option about your confidence level. Hopefully from today, your confidence might improve. And if not, then Boston Scientific certainly provide numerous different options where we can try and facilitate improving your confidence level if you wish to explore the use of three-piece devices. So thank you again to our audience for their viewpoints there. Really appreciate it. So Salah, let's look at the two-piece implant together.
Very well. So the only available two pieces penile prosthesis in our market is the Ambicor from Boston Scientific. As you can see, this piece have been introduced to the market in 1990, and it is a pre-connected and pre-filled prosthesis composed of a pair of silicone cylinders. And during inflation, the pump transfers the solution from the small reservoir that's located at the close to the rear end. You can see it here, the transparent part at the distal part of the cylinder for the inflation. And if you would like to deflate, the mechanism is different than compared to the three pieces. You have to break the cylinder to empty the fluid back to the little reservoir at the rear end. It's available in multiple sizes. The slide before that, please. The one before this. Yeah, it's available in different sizes and different also diameters. Next slide, please. And as I said, when you would like to deflate the prosthesis, you have to break it from the cylinder part to enforce the fluid back to the reservoir at the base of the cylinder. Because the reservoir is very little, then you should not expect much rigidity compared to the three pieces penile prosthesis where you have logically a larger reservoir. Next slide, please. So this is one patient that we have implanted. It's straightforward as any other approach. This is a peniscotal approach. You implant it in a similar way to the three pieces penile prosthesis without struggling with putting the reservoir in the space of Ritzius or in the ectopic position. Next slide, please. So this part compared to the three pieces is much easier to do. The disadvantage is the mechanical failure might be a little bit higher compared to the three pieces. It provides less firm erections than the 3 pieces because, as I said, the small amount of fluid, but it might be very enough to a certain group of patients. And a partial erection might be a bothersome for some men. It is the simplest inflatable implant surgical procedure, so that might be another compromise for those surgeons who are not comfortable in putting the reservoir in the space of Ritzius, or they are not comfortable putting an ectopic reservoir. Next slide, please. I would say this also option is manageable and open to any of your patients, but avoid that choice in a patient with a slim, thin penis, because the concealability might be an issue, and avoid also putting this in a patient who are expecting full flaccidity. Next slide, please. Post-operative consideration is same as the malleable prosthesis, but usually we start activating the pump after 4 weeks, and patient might resume sexual activity after usually between 5 and 6 weeks. Next slide, please. That will come to the end of my Ambicore. So this is just some hints to avoid any troubles when it comes to malleable and 2 pieces penile prosthesis. And I would say this also translates to your patients who will choose to go for 3 pieces penile prosthesis. Patient selection is a key and paramount. Patient preoperative evaluation, avoid at any time when there is a high risk for infection, coverage with antibiotic, and proper follow-up, and at the same time not to activate the prosthesis before you make sure there is no post-operative consequences. Next slide, please. And also to avoid trouble, try to avoid any cursed patients. Cursed patients are those patients who are compulsive, unrealistic, patients with previous failed prosthesis, and patients who are surgeon shoppings, and patients who think himself is entitled or in denial, or those psychiatric patients. Those patients, you have to look for them very carefully before importing or implanting them. Thank you.
Thank you very much for that, Salah. A really nice overview of malleables and also the 2-piece. I think many of our audience may not be as familiar with Ambicore as they might be with malleables or 3 pieces. So I really do appreciate your time and your overview on that. I'd like to now hand over to Gabriella. So Gabriella is going to look at the infrapubic approach in the moment. But before we do so, I'd like to again ask our audience a question regarding the infrapubic approach, because I know that many of you may be aware of it, but certainly may not be performing it at the moment. So what I would like to ask is, have you ever, or do you intend to consider the infrapubic approach now or in the future? So it may be that you don't currently use it. It might be that you have never used it, but might be considering it. Or it might be that you're already using it, such as Enrique, who does both approaches. Or it might be that you never have any intention to. So if you wouldn't mind sharing your thoughts and feelings on this at the moment, then that would be fantastic, just before we dive into the world of the infrapubic with Gabriella. Again, thank you for many of you already answering this, and I will share the results momentarily. Thank you. So I'm going to close the poll now. And interestingly, we have a broad range. What I find very interesting, and hopefully after today's lecture, maybe this will be a slightly different picture, but certainly a lot of you have never used it, but you might consider it in the future. And we'll look at some of the indications and considerations for that momentarily. Again, thank you for those of you who are very open, very honest, and have no intention of doing so in the future. We really do appreciate your openness and your transparency with that. So I would tell you that all of this is anonymous, and therefore none of these details will be shared with anybody. So thank you for providing that information for us. So, Gabriella, I would like to open your presentation around the infrapubic approach.
Okay.
Thank you.
Thank you. Next. Okay. I want to speak about the infrapubic approach, but in particular, I want to speak about the minimal invasive technique. Is the technique codified almost 12 years ago by Paul Perito. Is one of the most important surgeons about penile prosthesis implant all around the world, and one of the largest implanter in the United States. Next. We make an incision on the belly between the penis and the pubic bone, instead the scrotal approach. There is a psychological aspect. I'm speaking, next slide please. Why? Next. I'm speaking about the Italian situation. There is a psychological aspect. When you speak in Italy with a patient about a scar, an incision on the scrotum, the patient has a lot of fear. If you speak about an incision on the belly, it's very different, and the patient accepts better the surgery. Next. I had about 100 pinoscrotal approach before switch completely my technique. I've been in Miami to attend Paul Perito's course, and when I saw the technique, I was very fascinated by the technique. Why I decided to switch the technique? There are a lot of advantages. The skin incision is avoid the pump. It's very important. You know very well that the scrotum is a rich part of bacteria, and the skin has the scar tissue in 10 or 12 days. The incision on the belly is very quick, and after 7 days is perfectly closed. You can implant better the reservoir, because you can check very well if you have any damage, any artery damage of ectopic artery after the radical prostatectomy or after the cystectomy, and you can implant in ectopic position the reservoir without any problems, because you can check everything. You are very high, and you can implant the reservoir better than the pinoscrotal approach. The patient can feel the tubes. When you make the corporotomy with the pinoscrotal approach, the tubes comes out very superficial, and sometimes or every time the patient can feel the tubes or can feel the pump. With the infrapubic approach, we implant the tubes in the more distal part of the scrotum, and the patient can feel the tubes. Low risk of infection, because you make the incision on the belly, and I told you that the scrotum is very rich of bacteria, and the low risk is very is a reality. And the quickly rehabilitation is very important, because if the patient hasn't an incision on the scrotum can touch very quickly the pump and start the rehabilitation of the device. Next. Okay. if you have the video, we can see the video.
So I've just killed the music, Gabriella.
Yes, no problem. We put 2 stitches on the corpora. You can see very well how is the incision. It's very little. We make a little incision on the corpora cavernosa, just 1.5 centimeter to implant the cylinder. We make just only one dilatation, avoid to damage the corporal tissue. And you can see here, we are on the inguinal ring. We can perforate the transversalis fascia and implant the reservoir very safely. The video is just a little slow. We implant the cylinder. Before, I prefer implant before the proximal part and then the distal part. And then from the same incision, we implant the pump between the testes. These are the steps that Paul Perito codified 12 years ago, and this is the final result. The patient can feel the tubes. The incision is very little, small, 2 centimeters. Okay, next. Very important, the most important thing is the position. If you don't put in this position the patient, you can't have the infrapubic approach because you can't dilatate very well the corpora. Next. Only 2 centimeter incision. Next. Between the pubic bone and the penis. This is the picture of the paper that Perito published 12 years ago. Next. We make just a single dilatation to prevent any discomfort of the patient. With only one dilatation, you don't damage the arterial tissue, and the patient can feel very well the penis warm, can feel everything. It's very important to remember that this is a functional and aesthetical surgery. If you implant the prosthesis, but at the end of the procedure the patient has the cold penis, probably you haven't a good functional result. Next. We make the dilatation in the proximal part to the crura. Next. At the same time, we measure the length of the corpora. In this position, you can implant the reservoir in the space of retius, or you can implant the reservoir ectopic in ectopic position. Next. Okay, you can see in this picture we put the drain inside the scrotum, and we keep inside the drain about 3 or 4 days. Next. Very easy to implant the reservoir because you are on the inguinal ring and you can check everything. Next. Next. Very easy to check any injuries because you can see if you have an hole in the bladder, if you damage some artery. You can check everything. Next. And then in this position, from this position, you can implant the pump between the testes, and the patient can feel the tubes in the superficial part of the scrotum. Next. Next. Okay, we use the nasospeculum device retractor to implant the prosthesis. Next. Through the nasospeculum, we implant the pump. We open the nasospeculum retractor. Next. And we implant the pump. You can see the patient hasn't any incision on the scrotum and can start the rehabilitation of the prosthesis of the device after 7 days. This is the most important thing, because you know very well that the pseudocapsula gives to the patient a retraction of the length. If the patient starts quickly the activation and disactivation of the prosthesis, he can gain the length after 15 or 20 days, and without the incision on the scrotum, the patient hasn't pain, and can have the first, in our experience, the first sexual intercourse after 20 days. Okay, next. In this position, we can have also the scratch technique, is the technique codified by Perito for the Peyronie disease, to treat the Peyronie disease. Also, with the infrapubic approach, we can break the plaque without using any patch, any tissue, heterologous tissue, and we only break the plaque and then implant the prosthesis for the patient that has Peyronie disease. Next. I told you drain or not drain. Yes. Next. Drain. Always drain. I keep inside the drain for 3 or 4 days, because every day I have inside the drain about 25 or 30 ml of serum. And if you don't drain this, you can have a big hematoma on the scrotum, and the risk of infection can grow up. Next. Okay, next. Also, I keep the prosthesis inflate for 6 or 7 days, because the role of the prosthesis, of the inflate prosthesis, is to create an hemostasis and reduce the risk of bleeding and the hematoma. Next. The only risk of this technique is the damage of the neurovascular bundle. But if you know very well the anatomy, if you have an experience, a good experience on pinoscrotal approach, or a good experience on penile surgery, it's very difficult to damage the neurovascular bundle. Next.
Gabriella, can I just ask you a question on that? I know
Yes.
it's something we've discussed before, and I'd value actually all 3 of your opinions. If somebody is going to consider adopting the infrapubic approach, be it with the Perito technique or the classic infrapubic, what sort of experience level do you feel that they should have before they consider adopting it?
I think 30 or 40 pinoscrotal approach before starting the infrapubic, because if you don't have the good experience on pinoscrotal approach, You saw I work in a little space, only 2 centimeters. And if you haven't the sensibility and the experience and the knowledge of the anatomy, the risk to damage the neurovascular bundle of the urethra is very high. I think 30 or 40 pinoscrotal approach before starting.
Thank you. And Salah, what would you agree, or would you have a different opinion?
Yeah, I would totally agree. I think it is a 3-step approach, starting by malleable prosthesis. When you get advanced, you go for pinoscrotal inflatable prosthesis, and the infrapubic approach is the most luxurious, is the top end one. You should have a really good hands on the pinoscrotal before you embark on the infrapubic. I would say 30 to 40 cases is fair enough.
Thank you. And finally, Enrique, I know you've changed your practice over the last couple of years, and you've started to adopt the infrapubic as well. Would you agree with your 2 colleagues?
Yes, for sure. I am really in love with the infrapubic technique. I think that it's very, very nice technique. I enjoy every surgery I do. I think it's not so challenging. I mean, I agree with Gabriele that the risk of damaging the neurovascular bundle is very low, very low. And I think that probably, yes, 40, 50 pinoscrotal procedures before you start with the infrapubic approach, it's okay. And also to be proctored. I think that the first 5, 6 cases, you should be very taught and very well proctored before you start to do it by yourself, because probably especially the intraoperative complications could be completely different to the pinoscrotal technique. So
Thank you very much. Thank you. Gabriella.
Okay. The only contraindication, if you haven't experienced, is the massive fibrosis of the crura after the radiotherapy. Why? Because if you have the pinoscrotal approach, the length of the proximal part between the incision, the corporotomy, and the distal part of the crura is 6 or 7 centimeters. It's very low. It's very small. If you have the higher approach from the infrapubic part, the length of the incision between the corporotomy and the distal part of the crura is 11, 12 centimeters. And if you haven't a good ability, the risk of have a failure during the dilatation is very high. And disease is the only contraindication, but if you haven't a good experience on penile prosthesis implant. Next. This is my take-home message. The time is very important because if you are very, very quick, only 15 minutes to implant the device, the risk of infection is low, very, very low. Next. This is our experience. This is the first paper of Perito published in 2008. You can find on PubMed if you want. Next. These are our papers, and now we have almost 500 implants to speak about the infrapubic approach. Next. Next. Which are the reasons for dissatisfaction for the implants? Unrealistic expectation. You have to talk a lot with the patient. You have to explain very well the length, the final length of the penis. You know very well that at the end of the procedure, probably you can have a decrease in penis size. Other reason is do not have sex because you have the penile prosthesis, do not have sex for other reasons, no sense of naturalness, device malfunction. We have an experience of 1 or 2% of mechanical failure at the moment, which with both device, coloplast and BSC, reason related to the partners. Next. This is the reasons for satisfaction. Improve the sexual function, greater ease of erection, obtaining of vaginal penetration, the shortening of the penis break. Psychological factors, major change in life positive, emotion increased, self-increase in confidence with sex strengthening of masculine identity, self-image improvement. Relational factors, improvement of relations and the pleasure of the partners. Improvement in urinary function. Some patient, and you can see we have a paper of Enrique, some patient in my experience after radical prostatectomy with just a little urinary incontinence can solve the problem with the penile prosthesis, because the prosthesis gives to the urethra just a little compression, and some patient in our experience resolve the problem of little urinary incontinence. Next. These are some papers. You can see this. Next.
I think actually this is quite an important one. Of the questions that's come from the audience was about your experience with Peyronie's and penile prosthesis surgery. If we have time, we'll come back to that a little bit later. But I think the Montorsi paper here highlights the high potential satisfaction of patients with Peyronie's disease. So that's an interesting point. Thank you for adding that one, Gabriele.
Yeah. It's very important, the partner, the satisfaction of the partners is a key factor in overall satisfaction perceived by the man. Female sexual dysfunction is related to a low satisfaction rate of men with prosthetic implant, while a functional sexuality of the partner is associated with better functioning, greater post-operative satisfaction. Therefore, the opinion of the partners should always be taken into account in studies and surveys that assess the effectiveness of penile implant. Next. Erectile function is not enough, because next to recovery of erectile function should be associated the partner's elements related to sexuality, psychological dynamics, couple dynamics in a pre- and post-operative path. Next. What is important to offer? For sure, a psychological counseling is very important, in particular in patients after the oncological diseases. Very important to speak a lot with the patient, because the patient has a lot of fear for another procedure, and the role of the partner is very, very important to support the male to have another procedure. Next. Next, please. Next. This is very important. When the oncological aspect has been overcome, there is still the issue of attending to the psychological aspect and the sex life of the patient. In principle, the patient having undergone operation for prostate cancer are over age 60. Even if an early diagnosis, thanks to the introduction of PSA, can be made identifying the tumor as early as their 50. No one of these men that we should, having overcome the disease, give up an active and fulfilling sex life, which give us psychological and physical well-being and the energy to manage the disease as well. Next, I want to show how next we can manage the approach with the patient. Next, please. How important is how important is the doctor-patient relationship in these cases? Oncological pathology rightly takes up a lot of the time of the specialist, who in most cases, after having resolved the basic problem, then neglects the quality of the sex life, which creates a deep state of depression and frustration in the patient. The urologist must be completely dedicated to andrology or to the functional urology to be able to establish a rapport, a relation of friendship and trust with the patient, creating empathy between them and allowing the patient to open up and calmly deal with both the surgical phase and subsequent follow-up. Next. We work a lot on the web with our website. Next. Our website is only dedicated, our social web is only dedicated to the erectile dysfunction, to manage the erectile dysfunction after the diabetes, after the radical prostatectomy, and the patient loves very much the approach that we have. Next. Okay, next, sorry. We have a lot of web streaming meeting in this with Paul Perito from Rome. We had 1,060 contacts watching the surgery online. Next. We use a lot of masterclass to disseminate our technique and the role of the penile prosthesis to treat the erectile dysfunction. Next. This is a result after the procedure. We can see we keep inside the drain. This is the day before the procedure. No hematoma in the scrotum. You can see in the middle the pump. We keep inflate the prosthesis for 7 days. Next. This is another patient after I think 15 days. You can see the scar tissue in the infrapubic region. Next. Also in this picture, you can see this is a patient with Peyronie disease. After the procedure, the pain, after the scratch technique, the pain remain just a little curve, and after 1 or 2 months, the penis begin completely straight. Next. Okay, it's very important to communicate, in our experience, to communicate with the patient using the social media, using the web, to show our experience and to show to the patient the possibility to solve the problem with the penile prosthesis. If you are very skilled in the penile implant, I think is the best solution to treat the erectile dysfunction that doesn't respond to PDA5 inhibitors. Thank you.
Thank you very much, Gabriella. We do have another question from one of our participants. Alvaro, it's nice to see you here. Thank you for joining today. What about using the infrapubic approach for revision surgery? What are your thoughts as a faculty about that? Can I ask? And Gabriella first, thank you.
Yes, at the moment I'm using always infrapubic approach for the first implant, for the revision. It's very easy to remove the prosthesis and implant the new prosthesis. I'm using the pinoscrotal approach with the malleable because I saw that is better because you can have the incision largest, like Saleh told before, about 3 or sometimes 4 centimeters. But always I use the infrapubic approach for the first implant of the revision of the penile prosthesis, hydraulic penile prosthesis.
Thank you. In the interest of time, I'm going to continue. I appreciate we're running a little bit late, but I'm hoping most of you are still staying with us. So we're going to continue. And I'd like to reintroduce you to Enrique. And Enrique is going to look at the pinoscrotal approach, and some tips and tricks are related to that as well. So Enrique, over to you. Thank you.
Thank you, Russell. We can go ahead. Well, the pinoscrotal approach is probably the most used approach for the inflatable penile prosthesis. This not means that it's the best, but it's the most used. As I told you here, I think it's important that the surgical implantation of penile prosthesis has been considered among especially the European surgeons as a third-line therapy. I like more the vision of the American Urological Association, since I think that if there is a deal between the doctor and the patient, the penile prosthesis can be implanted at any time. I mean, if the patient has been diagnosed of prostate cancer and the patient is also suffering an erectile dysfunction, resistant to the PD5 inhibitors before the surgery, I think it's a silly thing to wait 1 year after the surgery if the patient is in this situation in order to implant the penile prosthesis. The election, the decision-making process should be done between intracavernosal injection or penile prosthesis. And I think there is no doubt that the best current treatment for erectile dysfunction most of the time, especially for patients with previous to the surgery erectile dysfunction, is the penile implants. We can go ahead, Russell. So penile implants is a really successful treatment. We published in the 2015 our rate, next slide, Russell, please, our rate of satisfaction among first and redo patients, penile implants, and also the partners, and the rate of satisfaction was over 85%. We can go ahead, Russell, please. So there is no doubt that there are some important points that we have to keep in mind, because I always say to my residents that penile prosthesis implant, independently of the technique you use, independently of the device you use, is not only surgery, but it's also the preoperative information to the patient and the partner, and the postoperative assessment to the patient. You are not only a good surgeon, but you have only to be a good communicator and overall a good doctor. So patient and the couple must be implanted completely informed and conscious of the expectations. Also, from a technical point of view, the surgery should be smooth and systematic. You have to be well taught. I was lucky because 30 years ago, I learned the technique with a very good friend of mine, Ignacio Moncada, and I have tried to give to my residents always the same teaching details and tips and tricks that I received at that time. And I think this is good to do the things always the same. And finally, I think it's not surgical, as I told you, surgical technique. It's important, the preoperative evaluation, the examination, physical examination of the patient, preparation of the genital skin, especially some days, a few days before the surgery, and also a deep knowledge of the penoscrotal anatomy. Let's go ahead, Russell, please. So this
just
time, it's important.
Just a quick question to the audience here. So as we can see, so I'm going to ask you all now, which approach do you currently use for your penile prosthesis? So we've discussed your thoughts around whether you may or may not consider an infrapubic in the future. But what we'd like to know now really is which approach are you currently using? So I'll just give you a minute or so to let us know what approach you're using in your current practice. And thank you for those of you who are already voting thick and fast. That's really appreciated. I'll just give you another few seconds on this one. Okay, thank you very much for all of you that that have voted. And I think we see what we would expect to see. The vast majority of you are performing penoscrotal. Again, I think based on the discussions we've had so far, that is the result we would expect to see. One or two of you are performing infrapubic. Interestingly, none of you are performing subcoronal. Again, that's not a very common technique. I know that in South Korea, for instance, a lot of the surgery is done subcoronally, but that is a unique phenomenon there. But again, thank you for just sharing your thoughts and also your current practice with us. Sorry for the interruption, Enrique. Let's continue through the step by step. Thank you.
Yes, I try to be to run fast and to especially stress the main tips and tricks.
Take your time.
The preparation, no, please. The preparation of the skin is very important. Not only the preoperative preparation, but also the intraoperative preparation. You must shave the patient at the OR, not before. Please cancel the surgery when the patient comes from home shaved. Don't accept this patient. The rate of infections is rising a lot. Also, we are very used to inject some povidone, povidone inside of the urethra. This is not forced. This is a thing that we do at our hospital, but it's not really, I think, crucial for the surgery. Next slide, please, Russell. Probably one, next slide, we go ahead. Yes, thank you. The preoperative urine culture, very important. In my opinion, 1 week before the surgery, you must test the urine in the patient and avoid any risk of infection. The next step is how to use the Scott retractor. I think that the Scott retractor is one of the most important assistants of the surgery. I like this opinion of Professor Wilson, and this is probably the most useful assistant, sometimes more important than the surgeon itself. I mean, the big part of the Scott retractor should be placed up, and the smaller part of the retractor should be placed down. This is the correct retractor configuration. Go ahead, and as long as we go ahead with the next slide, as long as we have placed the retractor, you go ahead with the incision. You can do in the penoscrotal approach 2 kinds of incision. the pure penoscrotal approach, I mean the longitudinal, and the transversal one. Probably the transversal one is more useful when you are going to perform a double implant, the 1500, the sphincter and prosthesis, because it gives you, we go ahead, Russell, a more accurate visualization of the proximal part of the urethra, as I tell you in this slide. We go ahead. The hooks of the retractor, next slide please, must be placed in this way. I mean 1, 5, 7, 11, and 3 and 9. This is the correct position. Also, some surgeons like to put a smaller hook in the meatus. I really don't like a lot so much, because sometimes you hit the glands, and this is not necessary. And usually you can use the catheter also to retract the penis to the upper part of the retractor. We go ahead. As long as you perform and you place the hooks, you go ahead with the dissection. Next slide, please. You go ahead with the dissection of the tissues around the corpus cavernosum, as you see, and the urethra. It's really important that you are, please, the previous, please, previous slide. It's very important that you are aware about the position of the corpus cavernosum, and you see the white and brilliant aspect of the albuginea and the darker aspect of the urethra. So this is the perfect presentation. Next slide. And at this time, you put the stitches. I usually put 4 stitches. Next slide, please. 4 stitches in each side using Vicryl, 2 stitches medial to the urethra and 2 stitches lateral to the urethra. And as long as you put these stitches, no, please, previous slide. As long as you put these stitches, you do the corporotomy. The corporotomy should not be higher than 2 centimeters most of the time. And at this point, you can, this is the corporotomy, you see the tissue of the corpus cavernosum, and at this time, you can go ahead with the dilatation of the corpus cavernosum. You can use, in the primary cases with not a really fibrotic tissue, corporal tissue, you can use the Metzenbaum scissors. Next slide, please. But either you use the Metzenbaum scissors or dilators, the most important thing is that you do it in the correct way. And the correct way is the left side way of doing. You must deform the lateral wall. This is the most important message to take home at this point, at this surgical step, because you leave away from the urethra. You avoid any risk of damaging the urethra, and you deform the lateral wall of the corpus cavernosum. This is the correct way of passaging the dilator, the Metzenbaum scissor, or the furlough inside of the corpus cavernosum. Also, the second point to keep in mind is that when you dilate or when you go through the proximal part of the corporotomy, think that the angle between the distal part of the corpus cavernosum and the proximal part of the corpus cavernosum is around 70 to 80 degrees. So you have to keep this in mind and reproduce the anatomy of the corpus cavernosum in order to dilate correctly the proximal part of the corpus cavernosum and don't perforate. Next slide, please. As long as you have also made the space in there. Yes? Yes?
Sorry, we've got a question from the audience. Yeah, we've got a question. If you've got a patient,
yes,
how long, if they have come in shaved, how long would you wait, and you discharge the patient without surgery, how long would you wait before you would actually bring that patient back to have the surgery, if they'd pre-shaved themselves at home?
Very good. Nice and very good question. I would put the patient on antibiotics, oral and topic, I would advise the patient to make shower with alcohol-based solutions, alcohol-based soap, and I would wait at least 1 month, not less, not less. This is my personal practice. It does not mean that is the best practice, but it's my own practice.
Okay, thank you. Sorry for interrupting.
So
thank you.
at this point, you can use or not use. Yes, no problem, please. It's okay. You can use or not use. Most of the times I don't use the dilators. You know perfectly that we have two types of dilators, the Brooks and the Hagar. Sometimes dilators produce more problems than advantages. I think that it's okay, it's enough. This is my practice to dilate the corpus cavernosum only with the maximum scissors and the furlough. I think most of the times it's enough, really. And we only, next slide, please. I only use the dilators when I have a really fibrotic patient, and I use in that cases the cavernotomes. In that cases, this is completely necessary and useful. But most of the first implant patients, this is not obviously necessary, neither to use the Brooks or Hagar dilators in my practice. Next slide, please. Anyway, you have safety maneuvers. Next click, please, to see the photographs. Next click, please. You have two very important and useful safety maneuvers. The first is to put some dilators, not really to dilate, but to see if they are symmetrical in the proximal part of the corpus cavernosum, to check if you have perforated the proximal part. This is not the objective of the talk, but you know that there is a perforation of the proximal part of the corpus cavernosum. You should not get scared. The only thing that you have to do is to use the sides of the cylinder of the non-perforated side and to put a spiral stitch in the tip of the extender, in the rear tip extender, and the stitch also in the albugina. And you introduce the cylinder in the perforated side, and no problem. This is the solution to manage the patient with a proximal perforation of the corpus cavernosum. Don't get nervous, it's not difficult, and there is always a solution for every problem. And in the right side, you see that you can irrigate the corpora and to check not only, this maneuver is not only to introduce antibiotic inside the corpora, but mainly to check if there is any flash of the solution from the urethra. It's very completely different to have a perforation of the proximal part of the urethra in the place where you perform the incision. In that place, you can try to fix with some sutures in comparison to the distal perforation of the urethra. Second important message to take home: if you perforate the distal urethra, please cancel the procedure. Leave a catheter in and come back in 1 month. This is the most useful way of doing things. Next slide, please. At this point, you have to make the size of the cylinders. Only remember that as long as in the penoscrotal approach, the proximal size of the cylinder is usually longer than the distal part, you have to use more rear tip extenders in comparison, for example, to the infrapubic approach. Usually, when you have a proximal size 2 centimeters longer than the distal size, you try to use longer rear tip extenders in comparison to shorter differences. This is important also to keep in mind. What is the reason for this? If you don't use enough rear tip extenders, the length of the tube that comes out from the corporotomy is short. And when the patient is activating the pump migrates to the penoscrotal angle, and the patient feels uncomfortable at the time of the penetration. So if you want the pump to go down to the scrotum, use a rear tip extender, and this produces a longer length of the tube coming out from the corporotomy and facilitates that the pump comes down to the bottom of the scrotum. This is the best way of avoiding any migration of the pump at the time of activating to the penoscrotal angle. Next slide, please, Russell. Well, at this time, you have also chosen the length of the cylinders. Next slide, please. And you have to prepare the device. You have to prepare both the pump and also to choose the cylinders. Please use cylinders with inhibizone. I think that in the introduction by Boston AMS of inhibizone is one of the hits in the last years in order to reduce the rate of infection. Very important, please. Use inhibizone cylinders. Next slide. And at this time, we are, next slide, please. At this time, we have to remember that the use of inhibizone is going to reduce the rate of infections, not only in first implants, but also, as Wilson referred, also especially in diabetic patients and in redo cases. Obviously, we have to introduce the cylinders. We use for this the furlough, and you pass the furlough, again deformating the lateral wall of the corpus cavernosum, and you pass the needle more or less 1 centimeter from the urethral meatus. This is the correct way of doing. Next slide. And at the time of introducing the cylinders, next slide, please. At the time, next slide, please. At the time of introducing the cylinders, I like to introduce first the proximal part of the cylinder in comparison, and the second and next the distal part of the cylinder. I prefer it. You can use, in order to introduce, pick up, as in the slide, or the device that is given by Boston, the blue device, the blue introductor that is given by Boston with all the set of the penile prosthesis. But I think that it's better to introduce first the proximal part of the cylinder, secondly the distal part of the cylinder. Next slide. After this, you check that there is no bends. You can close the corporotomy, as in the slide you see, and take out the orange silicone part that is around of the tube. It's better don't leave it in place because it does not give you any advantage and can produce you some problems, especially if you have any postoperative complication and you have to recheck the patient. Go ahead, next slide, please. Next
also,
slide.
Enrique,
Next.
sorry, Enrique. Also,
Yes.
in the revision, I had a lot of problem with the Dacron in the revision of the penile implant.
That's right. That's very important to keep in mind. I mean, that it's I have seen you, in fact, taking out this orange part of around the tube when you prepare the device. I think it's better because you are completely sure that you have eliminate all this silicone around the tube. This is important to keep in mind. All the Dacron, sorry. Next slide, please. And I think that at this point, next slide, you have to take out the Scott retractor. And at this time, we go ahead, next slide, with the placement of the reservoir. You have two ways of placing the reservoir. Next slide, you have to be sure that the bladder is empty. And next slide, I prefer to show you the video. You have two ways of placing the reservoir. The first way, this is the way you are going to do it. This is the limits. Here, the system is very, very important. The system must show you the upper part of the bone, the inguinal ring, and he does it retracting lateral the inguinal cord with the Deaver retractor, and you put the tip of your finger over the pubic bone inside of the inguinal ring. You put beside the tip of your finger the Metzenbaum scissor, and we are talking about the patient without previous radiotherapy, without previous radical cystectomy. You pierce at this moment the fascia transversalis. Be sure, please, that the bladder is empty. Don't go to the lateral side because there are the iliac vessels, and also don't go completely medial because there is the bladder. Go to the medium aspect and going probably mainly to the contralateral shoulder of the patient. This is a direction that you can take the scissor, and usually there is no problem doing things like this. Go ahead with the next slide. We have the video, and with this video, you can click on the video. This is the usual way of doing through the penoscrotal approach. You see the assistant is retracting lateral the inguinal cord, and you put the scissor over the pubic bone beside the tip of your finger, and you pierce the fascia transversalis with no problem, and you can, with the tip of your finger, feel the posterior part of the pubic bone. You are at that time at the retroperitoneal place, and put, you see here, and put place the reservoir beside the bladder. But the most important is that you always move inside of the inguinal ring. Please, this is very important. Next slide. If you have a patient with a radical cystectomy, kidney transplant, whatever, and you prefer, next slide, you see here, at this point, you see here the inguinal ring and how the scissor is piercing the fascia transversalis. This is the alternative way of doing things, the ectopic placement of the reservoir. You also put the finger inside of the inguinal ring, but instead of piercing the fascia transversalis, you maintain posterior to the rectus muscle, and you place the reservoir, and you can close the inguinal ring with an additional stitch, vicryl stitch, closing the inguinal ring and avoiding any risk of migration of the reservoir. Next slide, you see a video, and in this video, you can go ahead with the video, and you can see how, in this case, we are going to see clearly the inguinal ring, and you can go up to the level of the umbilicus and put the reservoir. In this case, this patient was a patient with a double implant. We use an ambicor because this was a kidney transplant patient and also a radical prostatectomy patient, and we put the reservoir of the sphincter through in the ectopical position. We didn't have any problem, and we also put a stitch of micryl in the inguinal ring in order to avoid the migration of the reservoir. So these are the two ways of placing the reservoir. Next slide, please, Russell. At this time, you only have to fill with, usually, if you use the concealed reservoir, it's enough with 65 cc's. For all the cylinders below 20 centimeters, 21 centimeters, is enough with 65 cc's. And finally, you can make a pocket in the scrotum. You can click the video, please. You can run the video, please, Russell. We can at this time do the pocket for the you see here, for the pump. You put the pump in the medium part of the scrotum, posterior to both testicles, but in a way that the patient is able to feel the pump part and the deactivation button. This is the way. After this, you can put or not put, leave or not leave drainage. Recently, I have almost always given up to leave drainage, and no problem has occurred. And this should be the final aspect. In relation to the postoperative, next slide, please, Russell. In relation to the postoperative questions, this should be very easy managed. I usually leave the prosthesis activated during 24 hours. In my previous setting, I left the patient for 24 hours at the hospital. Nowadays, I'm discharging the patient the same day. So I only leave the catheter in and the prosthesis activated for 4 to 6 hours. After this, I take out the catheter and deactivate partially the prosthesis, and I discharge the patient. I keep the patient on antibiotics, oral antibiotics, for at least 3 weeks, and I usually like to check the patient every week. It's very important. Please, this is my last message to take home. Please assess the patient. Is not only the surgery, is not only the time you spend doing the surgery, but also the patient must be happy. The patient is afraid. The patient is not really sure about what you have done most of the times, although you have been talking with the patient for a lot of time before the surgery, because the patient is nervous and the patient needs to meet you at least 2-3 times up to the point he becomes used to the situation. You have to teach him how to activate the prosthesis, and he ideally should be used to manage the pump of the prosthesis with you before he starts to function independently. I advise the patients don't to start to use the prosthesis never before 6 weeks. And these are my last messages. This is a very nice surgery. Please do it, because in my opinion, probably is the best treatment for erectile dysfunction most of the time. Thank you so much.
Thank you very, very much to all of our faculty. We really, really appreciate it. And I think your presentations today have been exemplary. So I do very much thank you for that. I think now it's really over to our audience as to whether you have any existing questions or not. I know that we do have 1 or 2 from the audience here. No, actually now, no, I think we've answered all the questions. Sorry, gentlemen, just bear with me a second. So I think we can bring today's meeting to a close. I would like to thank our faculty first and foremost, in order that they really have provided us with an extremely valuable and detailed explanation of the surgical techniques that they're adopting. And I would like to take this opportunity to thank all of our delegates as well that have attended this meeting and continue to stay with us despite us overrunning today. So again, I really appreciate that. For those of you who have attended the call, I apologize, I can't change my screen at the moment for some reason. For those of you who have attended today, we are able to share the screen, the deck that you've seen today with you, and certainly tomorrow I will make that possible. So you should receive an email from me. In terms of the video, we do need to take a couple of exceptions to that before we can share that with you as well. But certainly in the near future, we will also share that with you as well. For me, for today, we do have one final question. Alvaro, just some thank you to our faculty from our participants as well. For me, I'd just like to take this opportunity to thank all 3 of our faculty today. I think we can all agree they have provided an exemplary overview, and for me personally, it's been a pleasure to work with you all again. For tonight, we're finished. I hope all of you enjoy the rest of your summer vacation, and stay safe and stay very well. And I look forward to entertaining you all again at such similar events in the future. Thank you very much again, and good night. Take care. Bye-bye.
Good night. Thank you so much, Russell.
You're my pleasure. Thank you all. Thank you very, very much.
Bye-bye, Sale. Bye-bye, Gabriele.
Thank you, Russell. Thank you, Gabriel. Thank you, Enrique.
Good night. Bye-bye.
See you soon. Take care.